Yes, we can start now. We are live on the YouTube. Dr. Ravi, can switch on the video?
Yes.
Okay. So, good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. Today we have with us Dr. Ravi Shah. Actually, we had him a couple of years back, in February 23, so almost 3 years back. And he talked about defibrillation at that time. So to formally introduce him, he is MD, MBA, cardiologist and electrophysiologist practicing in USA. He is board certified in cardiology, echocardiography, internal medicine and general pediatrics. Multiple qualifications. Uh, he has passion for innovation in diagnostic and management technology, care delivery and healthcare policy. He was past VP strategy at 2 Minute Medicine company, then past chair health policy fellowship initiative, team lead and director of business development at Simplify, and recipient of AMA Foundation Leadership Award. So too many credits to his name. And today he is going to talk to about no, artificial intelligence in cardiology. We all know that AI is the buzzword these days. Every sphere of life we talk about AI. So today we'll be very happy to listen to Dr. Ravi Shah about artificial intelligence in cardiology. So thank you, Dr. Ravi, for joining us at this odd hour for you. I know 9:30 p.m. at your place, but thank you so
Yes.
much for joining us. And you have about 45 minutes to talk, and we'll have 10 minutes of discussion. So over to you, Dr. Ravi.
Okay. Dr. Satish, thank you very much. Thank you everyone for joining, and I appreciate your time. My research when I was in fellowship was about artificial intelligence in cardiology. So I would like to provide an overview, kind of general concepts in artificial intelligence, then focus in on medicine in artificial intelligence, then cardiology, and then just talk briefly about some of the research that we had done while I was in fellowship, and then continuing on today. So I'll just share my screen here. Okay.
Yes.
Okay, wonderful. So just basic objectives for this talk: to provide a basic understanding of artificial intelligence terminology, to discuss the impact of AI in medicine and cardiology, discuss current and future use cases, thoughts on using artificial intelligence algorithms in the real world, and then just personal research studies. But general themes as we think about artificial intelligence in the current milieu is that AI is already intertwined in our lives, but it will be further intertwined in our practice of medicine. Cardiology as a subspecialty is very well suited for AI inclusion in daily practice. The theme is, if you get on now, or you will get left behind. And it's also very important to understand that what we're seeing right now is still AI in medicine, but in its infancy. So there's a lot that will still be developed in the next few years. So real world examples, things that we're all familiar with right now, ChatGPT, but the larger umbrella is large language models, and then multimodal AI, where it's not just language, it's video, sounds, pictures, any kind of data that can be processed through an AI model. Facial recognition software, iRobot, which is a robot vacuum cleaner, self-driving software, word prediction in emails, and even smart thermostats. When we think about, terminology in AI, we have to think about, first, what is data science? And this is predictive analytics before, initially what were statistics and mathematical models. And then artificial intelligence is trying to enable machines to emulate human intelligence. Machine learning is automating the learning process for algorithms. Deep learning is still having that automation, but multi-layered, basically machine learning. And then that pairs in with big data. And so you're able to then use these models to learn from big data and process it. So why is it now that in this point in history, right, why is everyone so focused on this? So first and foremost is data availability, right? It's not just having the data, but it's having it in a form that it can be processed, that can be analyzed, and that's easily distributed. We have processing power now, right? Within our laptops, we have more processing power than probably the entire world did, just a few decades ago. There are improved algorithms. So, based off of some very intelligent research, there are algorithms now that have formed the paradigm for what is considered artificial intelligence, but that is just a small component of it. And then there's financial incentive, especially when you start talking about larger systems of healthcare. There is incentive on the payer side, right? If that's an insurance company to try to save money, there's incentive on the physician and healthcare system side to save money in the hospital, but also uh, rope in more patients and screen more patients. And then beyond that, better outcomes are more important uh, f- as we talk about population health. So, as far as AI in medicine goes, so just brief themes. So, in clinical medicine, we talk about skin lesion identification for skin cancers, gastrointestinal polyp identification as colonoscopies and endoscopies. For in the radiology lab and pathology lab, to very quickly pre-read and to find what are critical cases in this huge stack that we have to review. Obviously, within cardiology, we will talk about for ECG and echocardiography reads, but much beyond that. But when we talk about productivity and efficiency within healthcare and medicine, there are scribes taking notes, right, when we're in clinic, summarizing documentation, because there's now large amounts of data um, that is not categorized, not characterized, and needs to be. There's virtual patient intake and triage. And then again, just a link back to cardiology, even performing echocardiograms can be aided by artificial intelligence. When we talk about the larger system of healthcare, especially with insurance companies and whatnot, we think about prior authorization, risk stratification of certain populations, people with certain comorbidities, who is at higher risk for a bad outcome, who is at low risk, who can be discharged early, who will need to be readmitted, right? In population health, we talk about pandemic modeling and risk prediction again. And then research and development, right? So novel drug candidates, developing new technologies and for the operating room for procedural use, thinking about molecular physiology modeling, and our understanding of cell biology is all aided by artificial intelligence. Again, this is just another slide about terminology, which we've kind of gone over. But now, we are one step further than deep learning, where now we have generative AI, right? Where the AI can create. And is it always novel? Perhaps not, but it is a step forward. So just to understand machine learning, um, before where it was just rules-based, you have an input of data, you feed the computer rules, the computer processes the data based off of those rules and gives you an output. In machine learning, you give the computer the input and the output, and the computer can figure out what the rules are, right? So the input, for example, is in a clinical case that here's a patient with these risk factors, and this person then goes on to develop the output, which is this disease at this point in their lives. So you have input and output, and the computer's job is to figure out for thousands and tens of thousands of patients that what are the rules, right? What defines the likelihood of this patient being admitted or having a bad outcome early or needing certain medications. And so deep learning then is just one step further, right? Where often for machine learning, you have to extract certain features, right? Simplify it. In deep learning, you don't necessarily have to. You can feed all types of data, whether they're pictures, ECGs, clinical notes, lectures, anything at all, and it can process this together and give you an output. And so when we think about a neural network, right, it's analogous or not even analogous, but it's the same thing as talking about deep learning. But what we're trying to emulate is, how the brain functions, right? So any neuron will get multiple inputs, right? And then it processes those inputs and it gives some output, right? And this is a simplified version of it, but that's effectively what these algorithms are doing. In a convolutional neural network, you have multiple layers of these deep learning and machine learning algorithms that are learning, from each other and to give you an output. So again, it's just you need to feed it a lot more data, but the accuracy of the model increases as well. When we think about computer vision, right? So how can a computer look at an image and process it? It's that when it looks at an image, each pixel becomes some sort of symbol or number, right? That it can process. And then already we have a changing paradigm where we were thinking about just AI, ML, and deep learning, right? But now we think more about rules-based AI, supervised learning, and then unsupervised learning, right? And then having foundational models that can learn and then, become a more specialized model. So as we shift gears into thinking about applications within cardiology specifically, electrocardiograms are an easy target, and I'll talk about why. Echocardiograms, nuclear cardiology, right? Preventative cardiology, CTs and cardiac MRI, looking at the patient's voice to predict cardiac outcomes. When we're talking about in the interventional lab or in the electrophysiology lab, processing data that we do because of our practice, but also helping. So can you characterize how bad a coronary lesion is, right? How bad is that stenosis? And even if we're seeing it in 2 dimensions, can an algorithm process things in multiple dimensions and give us a better prediction than what our eyes are saying, or better than FFR, for example? Thinking about just degree of valvular disease in echocardiograms, that what is underpredicted, what is overcalled, and then large language models again for risk prediction, which we'll talk about. These were several journal articles and guidelines published by the societies here, kind of going over, some of the, I guess, finer applications, and which we'll talk about as well. But in ECGs, screening for structural disease, screening for atrial fibrillation, screening for asymptomatic LV dysfunction. From echocardiograms, aligning LVEF between what the AI is judging and what the sonographer is judging, better diagnosis of hypertrophic cardiomyopathy and amyloidosis, and then allowing users that don't have much practice, to get quality echocardiograms. For MRI, nuclear, and CT scanning, just automating some of the reads and increasing the speed at which you can put out certain reads, better understanding perivascular fat attenuation in coronary CTA, better characterizing late gadolinium enhancement on CMR, and then coronary angiography we've kind of already spoken about. And this is just one more slide that was part of one of the scientific documents that on the left side, right, these are the more obvious things. But when you think about a healthcare system, it's not just about clinical medicine, right? We then start thinking about overarching conversations about patient safety, data protection, thinking about bias and fairness about these algorithms, regulations, cybersecurity, and then clinical decision-making at point of care. So again, why cardiology? Cardiology as a specialty is heavily quantitative, right? We assign numbers to most things. There are a few things, other than diagnosis of heart failure, pericarditis, things that are like really clinically based, right? But there's a lot of quantitative data. But that data is also structured data. So for ECGs, what we see on a tracing on a 12-lead ECG is the result of code, right? Of XML code that we're seeing, just presented as an ECG. We also have adjudicated outcomes. So when you teach an algorithm, you need to have an input, right, which are the raw images, right, or the raw data, and you need to have an output to train it with. And the output is already adjudicated. There's a read already assigned to the data. You have a multitude of testing options, right? ECGs, echoes, MRI, CT scans. And as a specialty, it's a very cost-intensive specialty. So where you can save money, it is prudent for both patient and provider. When we think about application of AI to electrocardiograms, the first application was to ejection fraction. There was a paradigm shifting paper or a landmark paper in 2017 that talked about predicting the ejection fraction from a 12 lead ECG. And it's because there are certain features that are not visible to our naked eyes. Same way for hypertrophic cardiomyopathy, that we identify certain patterns with deep inverted T waves, right? For example, but still sometimes you can mistake that for something else, right? Screening for paroxysmal atrial fibrillation from a sinus rhythm ECG, for long QT syndrome, diagnosing aortic stenosis from an ECG, diagnosing pulmonary hypertension, underlying coronary artery disease that's not yet presented as angina, and even amyloidosis just from a sinus rhythm 12 lead ECG. So I wanted to speak about some of the data and some of these studies. So this trial was the culmination of years of research, but this was a kind of a landmark study where with 84% sensitivity and 83% specificity with an area under the receiver operating curve of 0.93 to predict LVEF, that's significantly reduced based off of a sinus rhythm ECG. In hypertrophic cardiomyopathy, you're able to, with an AUC of 0.96, diagnose based off of an ECG. And I served on one of these advisory boards for a company that was developing these algorithms. And truly, the sensitivity goes way up. However, the specificity is just as important. And we will talk about that a little bit in the future. For atrial fibrillation, with accuracy of about 0.87, 0.9% from a sinus rhythm ECG to predict underlying atrial fibrillation. And the implications of this are significant, that if you can diagnose somebody before they present with AFib with RVR or present with a cardiac embolic event, right, does that not change outcomes? And I think it does. Another algorithm for diagnosing aortic stenosis, right? Not everybody is so facile with listening to auscultation and understanding what aortic stenosis sounds like. And for the general practitioner or for somebody who's seen in the emergency department, having a clue as to what could be going on in somebody presenting with respiratory distress is very important. And certainly this can help. Now, there are other features on ECGs that are beyond just clinical entities, right? So can you use a 12 lead ECG as a biomarker for age? So they trained an AI algorithm to say that this person is X years old, and this is in 5 years, this is their 5-year mortality. And the algorithm, creates has pattern recognition of that. So looking at ECGs, when they had a random ECG without any outcome data, it was able to accurately predict mortality based off of the 12 lead ECG. And what's more interesting is that the age gap, which means that if the patient is 40 years old, but the AI predicts that the patient is 50 years old or 60 years old, that age gap was also predictive of all-cause mortality. So the bigger the age gap, right? So if the AI predicted that you were 50 years old and you were 30 years old, your hazard ratio for all-cause mortality was double where somebody was predicted at the accurate age. And the same held true for cardiovascular mortality. Again, what this is just showing us is that there's signals in the ECG that perhaps we're not seeing. This presents the same data. Now, this study was particularly interesting and I think very consequential. And a lot has been done since then. But in predicting diastolic function and filling pressures, often patients who have dyspnea on exertion, who have no other identifiable cause, so don't have coronary disease, don't have valvular dysfunction, right, can have diastolic dysfunction, and their volume overloaded. They have elevated filling pressures, but it's a difficult diagnosis, especially for non-cardiologists. So to have a tool that says that, okay, with a certain degree of certainty, this person has grade 2 or 3 diastolic dysfunction is significant. And with an AUC of zero point 0.9, these models were able to predict diastolic dysfunction. Even when there's comparison between ECG and echocardiography, the agreement was almost on 1-to-1, where what the echocardiogram was predicting was what the AI would then predict. Let's skip this. Now, shifting gears to echocardiography, predicting chamber volume, or sorry, measuring chamber volume, ejection fraction, looking at strain, and then heart failure with preserved ejection fraction are all clinical entities that could benefit from AI. So here we're looking at the agreement between AI, a gold standard, and what was manually measured in by an echocardiographer. And certainly the AI performed quite a bit better. This is another model looking at heart failure with preserved ejection fraction from a single view, right? So from an apical 4-chamber view, can you predict diastolic dysfunction? And most cardiologists and echocardiographers would say, no, you cannot, right? It doesn't need to meet all the criteria. You need more measurements, but still being trained on enough data, we are able to predict diastolic dysfunction based off of a single 4-chamber video clip. Now, the biggest part of all this is that you need a lot of data, right? So these models are trained on 10,000, 20,000, 30,000 studies, sometimes more, sometimes close to 100,000. And in the ECG world, trained on hundreds of thousands and millions of ECGs. Only then can you get a truly accurate model. Talk about CT and MRI in cardiology, again, used for image disk reconstruction, denoising images, super resolution, virtual native enhancement, volumetric evaluation, scar quantification, strain quantification, and again, disease and prognosis classification. This is just looking at LGE in a cardiac MRI with help of AI. Again, in nuclear cardiology, there are multiple uses as well to improve image quality, to improve diagnosis, risk prediction, to reduce radiation exposure, to decrease testing duration, and then quantification of non-cardiac findings. So there's often a lot more data than we are focused on as cardiologists, but it's important to look at other pieces of information that could inform your decision making. Preventative cardiology, obviously, being of Indian and South Asian descent, we are all at higher risk of coronary artery disease. And so, being able to predict who will, truly go on and develop plaque rupture or significant CAD or peripheral artery disease, it would be very helpful. And then also to help manage risk factors. This is looking at risk prediction for 10-year cardiovascular events using simply a language model. So looking through the patient's chart and looking at risk factors that way. And this performed pretty well. We'll skip this. And so in my specialty, in the electrophysiology lab, we already using AI for anatomy acquisition. So when we bring up intracardiac echocardiography, we're able to create a 3D model of the heart within a few seconds because an AI has been trained on how to identify borders within the left atrium and the left ventricle and whatnot. identification of target substrate. So we try to map the inside of the heart, but sometimes you miss things or there's fractionated potentials that can get confusing about what to ablate. But these technologies can help. Um, Predicting risk of arrhythmia recurrence. So if you do an atrial fibrillation ablation or SVT ablation or VT ablation, who will have recurrence of their arrhythmias and who will need to come back? And then CRT response as well. So for cardiovascular, for resynchronization therapy, you're able to then predict who is going to respond and who will not respond. So this is also very interesting, right? Other applications that relate to adjacent fields. So how about obstetrics? So based off of this model that from the Mayo Clinic here, the team went to try to predict peripartum cardiomyopathy. And can you, based off of a single lead ECG, use as a screening tool in OBGYN clinic, find patients who have a reduced ejection fraction in resource limited settings? And so this was a couple of years ago now, but this was a trial in Nigeria, actually. And so an AI-guided screening resulted in double the number of identified cardiomyopathy cases. And this was done via a single lead ECG on a stethoscope. And so clearly, if you identify these patients sooner, they can be intervened on and their morbidity and mortality improves. And I would say that in India, we certainly need that as well. This applying these algorithms in real time, though, is really interesting. So this is a dashboard developed at the Mayo Clinic, but multiple other sites have this now. And we're getting used to it. Once you have multiple algorithms, you can apply them simultaneously to an ECG and predict if a patient has probability of low EF, hypertrophic cardiomyopathy, probability of silent atrial fibrillation or aortic stenosis, amyloidosis. What is their predicted age, right? And so for this patient, everything checked out, but it did seem like after a certain point, the ECG reading changed. So ECGs from 1990 did not predict he had atrial fibrillation, but by the 2000s, there were features that put him at higher risk for having subclinical atrial fibrillation, and then he was diagnosed with it. And then that can be applied in other disease states as well. So we talked about examples now. How do you do this, right? You need a large volume of data. That data has to be accurately labeled. It needs to be annotated and linked to outcomes. You need easy access to the data. And then I would say equally as important is this cannot be done by just engineers, but by computer engineers. You definitely need to work with clinical staff to be able to fine-tune these algorithms. There's also an emphasis on prospective validation. So just because you are approved by the FDA or you have a CE mark or any regulatory agency has approved the technology doesn't mean that it will perform the exact same way in the real world. The path to true validation with real-world data is long. And then understanding the limitations of these algorithms is crucial. And so when we use these without understanding limitations, like any other test that we do, you will either be blinded to certain outcomes or you will anchor on certain diagnoses and miss other more important ones. So challenges with AI, right? How do we evaluate models and how do we evaluate bias? So the basics of sensitivity and specificity are expanded a bit now, right? We need to understand what the precision is of the model, what is the accuracy is, what is the F1 score, right? And so you'll be hearing this more as these models get applied. And so we need to expand our thinking from just sensitivity specificity to, again, these other measures of model performance. Explainability, right? So just because the model predicts something and it might be accurate, but why? And medicine is based off of the why. And so we need to focus on explainability. And so what this chart shows is that when we started off with linear regression, right, it's easily interpretable. But as you get over to deep learning models and AI models, some of the interpretability and the explainability suffers, but your predictive power goes up. This is something called the saliency map, and this is from a study about predicting atrial fibrillation. And so where you see a dark purple line is where the algorithm was focusing in on, and that is where it was getting a lot of its risk prediction. And so what you see here is this is again just a 12-lead ECG, and it is focusing in on the P wave and looking at who is at lower risk and higher risk. There are different parts of the P wave still that make that prediction more or less accurate. Does improved screening equal improved outcomes, right? And so this is particularly important in coronary disease, right? Just because I identify somebody with coronary disease, does it mean that they are going to present with an MI? Will their longevity be any different for my having diagnosed things earlier? Is there overdiagnosis because of improved screening? These are all kind of discussions that will be had more and more. And then what is the clinical burden of increased diagnoses? So again, I was on an advisory board for a company developing a hypertrophic cardiomyopathy algorithm. And when you screen a lot of people, right, because the positive predictive value was not super high for the algorithm, you get a lot of false positives. And you do get true positives, more than you would have otherwise. But then who processes that information, right? Somebody has to be responsible for then contacting the patient, doing more testing. And at what point is it worthwhile to do all that testing compared to what we're doing currently? And then finally, who pays for this, right? Who is the consumer? Is it the patient? Is it the insurance company? Is it the hospital system? Is it the government? Who is responsible for paying for this, and who would want to pay for it? Who is going to benefit truly? So when we think about, how we progress in, or how we have progressed in medicine, when we first started out, hundreds of years or thousands of years ago in India, right? It's by diagnosis. What is the problem? First, figuring out that these are different problems, even that look the same way, getting an accurate diagnosis. And then we progress to management and prognosis, right? So now that we've identified the problem, let's figure out what we can do about it, and then what will probably happen to you. And then finally, we have moved to prevention. That let's prevent this diagnosis from presenting in the first place, right? So again, with coronary artery disease being the model example, let's eat healthier foods, exercise more, have your glucose under control, less salt. That is all prevention to prevent that diagnosis from even being, from coming into being. And the same paradigm is for artificial intelligence. So the algorithms have moved from diagnosis to helping with management, right? And prognosis. That can you predict in somebody who's already sick, who is going to have a bad outcome? Who should I focus more on? Who needs to be upgraded to the ICU, right? Who can be discharged? Who needs to come back sooner for an outpatient follow-up? And then we will soon move to prevention, right? That predicting somebody who will have increased mortality and morbidity, what resources do they need? And how will it cost the system less? How can we improve their outcomes? So when I was in fellowship, we did some research on what's called embolic stroke of unknown source, or also known as cryptogenic stroke. And again, there's fine differences in those definitions, but just for this talk, we'll call it ESIS or cryptogenic stroke interchangeably. 20 to 40% of patients who suffer cryptogenic stroke will have subclinical atrial fibrillation, right? Diagnosed um, very soon thereafter, or sorry, have some subclinical atrial fibrillation that can be diagnosed there soon after. And so we will typically implant what's called a loop recorder in these patients. And so that loop recorder then just monitors the rhythm for the next 3 to 6 years. And if we find atrial fibrillation, we start anticoagulation for secondary prevention of a stroke. And so Dr. Maheshwari, Ankit Maheshwari was one of my attendings when I was in fellowship. And he had done some research on thinking about abnormal P wave access and ischemic stroke. So now there's some biologic plausibility there. We had studied echocardiographic parameters there, but we knew that there are signals there that we don't recognize that well that can help predict who has atrial fibrillation. So we embarked on doing a study where we looked at everybody who had a loop recorder implanted over a 5-year period. And I personally went through all of the reads and the data to categorize people in patients who were diagnosed with AFib and patients who were not diagnosed with AFib. And then we looked at their baseline sinus rhythm ECGs. And then we tried to train a model on this. But the problem with these studies specifically is that you don't have a lot of data. At most, you have a couple of hundred patients, right? Or maybe up to 500 if you're very lucky. So we had to find a way to augment the data. And so when you look at a 12-lead ECG, you see PQRST. Now, each PQRST is a separate piece of information, right? And so when we think about augmenting data, we think about from what we have, how can we feed in more into the algorithm? And so what we realized that even in a single beat, because each single beat is recorded over 12 channels, right? That there's a lot of data in just a single beat. So can you use then a single beat and a single part of each beat to diagnose subclinical atrial fibrillation? So this is what we looked at, essentially, that the same 12-lead ECG, we looked at a single heartbeat. So when we put it into the computer, we programmed it to analyze between each P wave and each T wave. And even though this looks grainy, again, this was good enough. And we wanted to look at a full cardiac cycle, not just the P wave, because there are sometimes signals in the T wave as well. And so what we were able to develop is a model that has fairly good accuracy, that with a specificity of 0.83, we were able to say, okay, this person will not have atrial fibrillation, right? We were not very good at diagnosing it. Our sensitivity was poor, but our specificity was quite good. And our AUC was 0.72, which meets a lot of the risk calculators we have with just a sample size of 150 patients or so. So there's a lot that we can do, again, with AI. This is just a small example of what's possible. And so these were just some of my team members when we did these studies. That's all. All righty. Thank you. I will take any questions.
Yes. Thank you, Dr. Ravi. An excellent informative talk. You can stop the screen sharing so we can have some more participants.
I have a question. Can
Yes,
you
yes.
expand upon F1 score? What is that, and what is a good score? What is a bad score?
Yeah, that's a great question. Let me just pull up. Yeah. So when we're looking at the F1 score, I don't have the exact values for what is considered a good score and a bad score. higher, closer to a 0.5 and above is considered a better score. But it's when you think about it, you have to look at it in the context of your specificity, sensitivity, and your accuracy. That only looking at the F1 score is not enough in these models. But it's supposed to include measures of your basic parameters, sensitivity and specificity in the calculation of it.
Any other comments or questions?
Dr. Pandya, if I can come in?
Yeah, please, Dr. Jagdish.
Yeah. So thank you very much. That was a very fascinating, presentation. Some of the issues are, one is there are ethnic differences. How do you look at correcting for that?
Yeah, that's a very good question. And this is something that is often discussed when we think about models, that what is the generalizability, right? So can you apply a model that was trained on, Caucasian and African American patients to Indian patients, right? And the answer is not always. That validation has to be performed first, but oftentimes you find that it cannot be applied directly.
Thank you. The second problem is that, the advantage that the US has is that you have a large amount of computing power available, the various GPUs, etc. In India, the challenge is going to be to process this data, because we are trying to process some data, but we have to hire the GPUs from NVIDIA in the US, and they are extremely expensive. They cost they almost cost about $12 an hour. So to get any kind of large data processing from our country is restricted by the amount of, computing power that we have.
Yeah, if you don't mind me asking, is this in an academic context, or is this in a entrepreneurial context?
We are looking at basically a combination of both, because we don't have any funding for an academic trial. So we are trying to look at how to do this on a, quasi-academic commercial model where we can process data.
Interesting. And then who is your partner? Are you trying to do it with the university, or are you trying to do it?
No, it's through a AI agency. Means the AI, there is an AI group which is looking at it, and we are trying to process some data. And the problem is we are running up with, because tremendously expensive computing costs. So these are the issues that we probably will face.
So I think there are, again, thank you for this kind of thoughts on this, but it's interesting. For us, we were only able to do this because we were paired with an academic university. So what I did was I reached out to the College of Engineering from Penn State and said, hey, you have resources, right? You have computing power. And then we have data, and we have the want to process this data, right? And to create something, a research collaboration. I would recommend doing the same. Now, because the engineering schools already have that processing power, right? And India hopefully will have their own chip manufacturing soon, where some of this cost will come.
True. And
But
in fact,
yeah.
Yeah, please go ahead. Yeah.
No. But it's probably going to be a few years until it's easily commercially available.
Yeah.
But there will probably be universities that are willing to partner, even for just PhD students, master's students doing their thesis and whatnot, to help.
Yeah. So I think we have explored that too. But let's see we are having a meeting next week on this. So let's hope that something comes out of. The last question I had was the fascinating data that you presented on the ECG predicting outcomes, age-related outcomes.
Yeah.
Is it now worthwhile doing ECG in adolescents to see how they progress?
So this is to your point that, can you apply the models to different populations, right? Same thing, that if the model is trained only on patients between 18 years and 80 years, right? Can you apply that model to a 12-year-old or 13, 14-year-old patient? And the answer is not always. Because, right, ECG signatures for juvenile patients are very different than adult patients, right? Like just persistence of juvenile T waves, right, is just a very simple example of that. So the model will not know what it's looking at. And so, for example, right, if I apply a model for hypertrophic cardiomyopathy that's trained on adults to a patient, to a pediatric patient, but who has persistent of some anterior T wave inversions, that model may say that this patient has hypertrophic cardiomyopathy because it hasn't seen this before. And the patterns that it recognizes are from adults who have HCM, not of healthy children who may also have inverted T waves, for example. It just has to be validated. And that validation is challenging.
Yeah. Thank you. Thank you for those that clarification.
Yeah.
Thank you.
And if you ever want to kind of discuss strategy and how to do this, I consult for some of these companies that are trying to develop models, and what the clinical connections are with the engineers. Happy to talk anytime.
Thank you. Thank you so much. I will get your contact from Dr. Pandya. Thank you so much.
So, to introduce Dr. Jagdish Chinnappa, he's a pediatrician associated with Manipal Hospitals, Bangalore, and a very active academician also.
Thank you. Thank you, Satish.
Satish
So,
bhai,
yes, Hemant, yes. Yeah, Hemant. He lost connection. Yes, Hemant, you are saying something? Anyway, in context of your simplified approach with ECG, I mean, there are a lot of young deaths happening in India these days. So will this be able to help predict certain events, cardiac events in a population site, sort of a screening like the many healthy fit people also collapse in gyms,
Jagdish,
on the walking track, etc.
Jagdish, you are in Bangalore, which has got NCBS. Dr. Shashidhara was there last week. Jagdish.
Yes, sir. Yes, sir. Listening, sir.
You can contact Dr. Shashidhara, who was here last week.
Yeah.
And as all the 3-4 children and daughter-in-law in data science,
Okay.
I know something about it.
Right.
That IISc has a National Institute of Advanced Studies. Those professors can help. And IISc has a translational department headed by Namrata Gundecha. And our own from Barodian called Dr. Raghavan Varadarajan. So they have huge computing capacity. And they can collaborate.
Yeah, thank you, sir, for mentioning that. Our collaborator at Penn State College of Engineering was Dr. Vasant Honavar, who is one of the top AI minds in the world, but he's Indian, and he has connections back to India, probably at IIT, and so those are connections that I would explore.
Yeah, coming back to my question, about predicting cardiac events in young population. Yeah.
Yes. So predicting sudden cardiac death it's a big field of study in AI and ECG, but I haven't seen any models yet, because the problem is when you have those sudden deaths, right? And this is from an electrophysiology standpoint, this is sudden cardiac death is a focus in EP. They are usually not patients who have been in the medical system, right? So I had a young patient, South Indian patient, just 2 months ago, whose father had died at 50. A very common story, right? Suddenly died at 50. He comes in, he was playing tennis at the gym, leaves, is walking out, and then collapses. And they do a coronary angiography. He's a CTO of his RCA, right? Already at the age of 50. And he has collaterals, but he also has one culprit vessel. But he's only 50 years old. And so those are the patients who we know have strong family histories, who we should be including in data cohorts to then train the models. This is the challenging part.
Ravi,
but you never had an ECG before.
Right.
Ravi,
Yes, sir.
ECG shows the effects, not the root cause. Because I myself, I was a clinical head. I got 16 lead ECG twice, went to cath lab because I knew about this thing, cardiac emergency. Again, 2 leads for 2 hours, and I survived 100% soft clot LAD just because I was aware that these symptoms and 4 ECGs were normal within 2 hours. So ECG cannot be guide for ischemic heart disease, and it cannot prevent sudden cardiac death.
So it's a very good point, Dr. Hemant. The thing is that so what these models are saying is that there are things that clinicians are not picking up, right? That there are subtle clues that even though we cannot visually see it, but there are features in the model that tell you about subclinical disease. And it won't be 100%, but can we get more patients in, right? Can we identify 30%, 40% more people before they get to the point where, they have 100% soft plaque or, that they have a cardiac arrest. So that's what's special about these models.
I have another question. My name is Kiran Modi. I am a general cardiologist here in Florida. How about picking up signal average ECG for sudden cardiac death and diagnosis of Brugada syndrome using AI?
Yeah. Again, there's a whole initiative to look at pediatric sudden cardiac death, and identifying Brugada, just the whole long QT, CPVT, basically any channelopathy, right? What we see on the ECG is a result of that individual person's particular channels, right? Whatever alleles they have specifically, the combination of them results in the ECG that we see. So can you predict what a patient's genetics are based off of their ECG? And yes, I think to a degree you can, but the amount of data you need to create those models is vast. I mean, the ECG models that I presented were trained on over many hundreds of thousands of ECGs, right? We're talking about over 1 million ECGs, and Mayo Clinic has all of their data is so cleanly categorized, and that's why they've been successful in this. They were able to say that, they've always been ahead of the curve, but they were able to say, we want to do this project. We already have 30 years of data, right? That is clean, it is adjudicated, and we've already digitized it, that we can plug into these models very easily. So what they have is they have a sandbox, right? They have all this data existing, whether it's ECGs, echo, just clinical data, right? Notes and whatnot. And they have engineers that can easily access that to work on models. And they've bought computing power, obviously. Other systems where the same project that I presented, it took me 3 years of effort to get to this point, or 4 years of effort, because we're missing certain software. We don't have the clinical data categorized in the way that we need to, right? A lot of institutions caught up with this. So when you look at Mount Sinai is another powerhouse, there's a guy at Yale, Stanford, right? All of these institutions put a lot of money into structuring the data and making it easily available. And that is the key to success here. Because when you speak with the engineers, right, they're good at engineering. They're good at developing the models, but they don't know what the inputs are and they don't know what the relevant outputs are. And so when we were working on this project, right, it was important to say to them that, listen, it's important to predict AFib, but it's equally as important to say who will not have AFib, right? That if I can say with 95% certainty that you won't have AFib, do you need a loop recorder, right? Do you need long-term monitoring? Probably not, right? And so that takes care of a large chunk of patients.
Good point.
Yeah. Dr. Hemant, your microphone is off.
Radiology has taken a lot of here. Our routine radiology, X-ray screening, and sonography screening, lot of private radiologists in Vadodara are using for X-ray chest and HT, CT, HT, for in COVID era also. We manufactured new COVID Indian vaccine within 1 year using AI, but Rapid AI company in California is using radiology, CT angio and MRI angio for prevention of stroke.
Yeah. So the next step here, right, is,
And my brother-in-law has developed that software.
oh, that's amazing. It's amazing. When you look at the progression, how this will progress, right? So right now it's siloed, or it was, right? So you have ECG AI, you have Echo AI, you have CT AI, right? All these things. But multimodal AI is combining all of that data, right? And then predicting an outcome. So if I had just ECG data, my accuracy, let's say, will be 0.8. If I had just echo, it'll be 0.8. But if I had ECG and echo data together, my prediction is going to be much, much better, right? And so combining all the different modes of data that we have will lead to better prediction. And again, even beyond prediction, then it will be management. But in this particular patient, was this classification of disease, what is the best course of action?
So Ravi, imagine after the ECG is normal, but clinically the person is showing the evidence of cardiac problem. If he is going for CT angio screening, AI will immediately tell the clinician that there is a chance of a big shutdown, coronary.
Yeah. So
Might.
CT angiography will tell you plaque burden immediately. But what the AI agents and the algorithms were, one of the more famous ones here, right, is to say that if a radiologist has 100 studies to read, right, which one of those should he read first, right? And so there's this company, Viz, that got their FDA approval based off of that. They said it was for brain imaging, right? That who has a critical finding that should be read first? Who should be at top of the list, right, from the ED? And who needs to be seen by neurosurgery immediately or neurology? But to that same point, that if you do a CT angiography, right, the radiologist can't read it immediately. Who needs to be picked out quickly? Look at that first, confirm the results, and then call the cardiologist or the neurologist.
Okay. Thank you, Ravi. That was wonderful. And
Yeah.
thank you all for a very interactive,
Thank you,
session.
everyone.
Because it's already 9 o'clock. Now we'll end the session here. Thank you, Dr. Ravi. We look forward to such more talks in future. So I'll get
Yes.
back to you again.
Please. Pleasure speaking with all of you. Thank you.
Thank you. Thank you.
Thank you. Thank you, Satish and Ravi.
Thank
It
you.
was a wonderful session. Thank you.
So next Saturday, we again will have a speaker from USA, Dr. Sapna Patel, she'll be talking about dementia. I will share the flyer shortly. Thank you. Thank you all. Please join next Saturday.